Hello, my name is Peter Abraham. Welcome to my channel. If you're new here, I'm so thankful that you're visiting. I am a second career registered nurse with extensive hospice and palliative care experience. I'm also an holistic nurse treating mind, body, spirit, and soul. And I am an end-of-life doula, also known as a death doula or life transition coach. I'm an avid book reader and author, having written many guides for my fellow hospice nurses, holistic nurses, caregivers, and end-of-life professionals such as doulas. In this channel, we talk about things related to death and dying. We are all going to die, and it should not be a mystery or a stigma. We should be able to have open and positive conversations about death and dying. Over time, I will have video discussions for my fellow hospice nurses, holistic nurses, death doulas. Today's discussion is going to be showing the presentation that I am doing for the Visiting Angels of Richmond, Kentucky. If you've watched the previous episode, which was for my fellow hospice nurses, this one is for my fellow end-of-life professionals. Anyone who's been watching any of my videos know that part of my character personality, I want to be transparent to each and every one of you. So this service offering that I'm doing for the Visiting Angels of Richmond, Kentucky, the agreement is free 2 hours. I'm doing two 1 hour back-to-back presentations. It's the same presentation to two different groups of caregivers that are coming in to learn more about hospice and palliative care. And the agreement is that if they like what they see, they're going to call me back and we'll discuss how that would work from a compensation point of view. So what you're about to see is free to them and therefore free to you. And I'm hoping that will be of value to you. Now I'm timing the release. This is currently being filmed on Tuesday, July 1st of 2025. I'm going to be scheduling it to be released on YouTube for 11 a.m., which is about the time I'm going to be starting at the Visiting Angels of Richmond, Kentucky. So while you won't be there in person with me, you'll be there in spirit with me. And so that you are aware that while I do have the slides pre-prepared, I am doing everything from my experience and my memory. So what I share, what you're going to see, might not be word for what the first group is going to hear and see, and it might not be word for what the second group is going to see. I know some people use teleprompters, and there's nothing wrong with that, depending on the circumstances. But my thought process is if I'm somebody's hospice nurse or I'm their end-of-life doula or life transition support guide, I'm not going to be having a teleprompter with me. I need to be able to do this on my own. And while I do believe AI has a place and a purpose, I'm not going to be able to rely on AI to back me up. I have to be able to do this live in real time. So I'm hoping that you're going to enjoy what you're about to see. If you have any questions, this is a non-judgmental channel, and I'll mention non-judgmental when we get into the presentation. But ask your questions. It is unbelievably hard to offend me. I try to love everyone around me and care for them as I am able. Before we get into the actual presentation, which will be me in showing the actual presentation on the screen, I do want to stop and ask what I ask all my viewers to reflect on before we start. What are you grateful for? Where are the areas of gratitude in your life? Because one of the topics that's going to be in today's videos towards the very end is anticipatory grief and grieving. And in my experience of working with people who are dying or chronically ill and getting worse and worse and worse, and today, for example, with that, I was going through a lot of my photographs that I had over the years, just trying to find pictures that might be fitting for some of the slides. And I was just recalling my own a family, the deaths that have occurred, and how much it reminded me that people do start dying about a year or two before actual death. And then I'm going through those feelings of grief. But I strongly believe that when we are resilient, resilient means to snap back, that the feelings don't tackle us to the floor and hold us down. So for me, for resilience, it is my faith in Christ Jesus. I was going to reach for my Bible, but my faith's not in the Bible, it's in the person who is alive and living. And I'm not trying to preach at or to you, but my faith is in Christ Jesus. So that's part of my resilience. My other part of resilience is on a regular basis. Do I have to forgive anybody? I struggle with that. There are times like I thought I forgave somebody, and the thoughts will come back, and maybe I haven't. I'm still working on it. I'm a work in progress. I shared in previous videos I'm broken. But what I find that everyone can do, and I'm not saying that it's not a struggle, because there are days. It's hard to find what are you grateful for? What do you have gratitude? And for me, as I'm looking, now this is future gratitude. I am so grateful for this opportunity to go to Richmond, Kentucky tomorrow. And again, when you see this, I'm probably already there, probably got there early, but I'm so happy to be able to present to two different care teams there and have this opportunity. Because if you're a fellow end of life professional, you're asking, how do I get my business going? I cannot enforce enough free education, workshops, seminars. You're getting your name out there. And again, with this particular one, I've arranged, this was a discussion when I talked to the assistant director there. I said, I'm brand new to Kentucky. We came here late last year. I just started Compassion Crossing LLC. I've had the website for years, compassioncrossing.info. I am good at this. I believe I have something to offer. I believe it's valuable. But I also believe that I can't stress this enough, because this is part of my vision for Madison County, Kentucky. I get passionate about this, so if I get teary-eyed, it's part of my heart that I do want to have a nonprofit as part of this picture. We're not at the nonprofit stage yet, but I want to give back, and this is my way of giving back to them. But I do believe that if they see the value in what I'm giving, they're going to ask me. They're going to ask me to come back and do staff development again. So that's where I'm grateful for, and I want to move on, just so that you are aware in terms of housekeeping. There'll be housekeeping mentioned when we get to the presentation, because that's going to be a part of that. But for the housekeeping now of the intro section is this is going to be towards 60 minutes. My intro's part of the picture, so that'll add to that. And you'll see the time when it gets to YouTube, how long this is, but the actual presentation is about 45 to 50 minutes, give or take, of speaking, and then questions and answers at the end. Now, chances are very high, depending on how tomorrow goes, that you may get a 2 for the price of 1, which is free. I might put another video of how Wednesday went after, like live Wednesday, so to speak, or I may save that for Friday's publication on YouTube. Don't know. But for now, I'm so happy to be able to share this with you. Please comment below. There will not be an outro. The outro will, when I get to the question and answer slide, that will be the outro for this video. Again, non-judgmental channel. If you like what you're seeing, you like this type of thing, subscribe. Hit the bell notification so you get notified when videos are put up. And please like the video if you do like it. It does help with the YouTube algorithm. Let's get now going. And thank you. Hello, I am so grateful to be here today. My name is Peter Abraham. I am a second career registered nurse with extensive hospice and palliative care experience. I enjoy full transparency, so that experience, all my nursing experience in reality, is from up in Pennsylvania. Our family moved to Madison County, Kentucky late last year. And after moving to the area, I realized that, like many areas of the country, this area is lacking in education on options for palliative care and hospice care. And how do we proceed from critical illness to terminal illness, and what are the choices, and how to best advocate for those that need end of life care. So that's why we started Compassion Crossing LLC. Even though compassioncrossing.info, the website, has been available for several years and now has over 400 free articles for caregivers like yourselves, patients, families, nurses alike, on chronic illness, terminal illness, and so forth. Today, I'm so honored to be here. We have a jam-packed session. In all reality, what we're covering today in the best world would be 2 or 3 presentations versus 1, but we're going to try to make this go through in terms of what we're going to see on the screen and various handouts that you'll be given throughout the presentation. Some housekeeping. I absolutely adore what I do for a living. What that means to you is I love it so much that all questions are good questions. This is a non-judgmental space. You're not going to offend me, and you're not going to ask me a question that I've never heard before, might not be able to answer it, but it's a non-judgmental space. So as you have questions, the way this is going to work, I have about 45, 50 minutes of presentation material and then space at the end for questions and answers. However, if you're like me, where my short-term memory is like that of a butterfly, if you feel like, gee, I can't wait until the end, I'm going to forget, raise your hand, ask the question, we'll work through. Now, there's 3 types of questions. There's questions I can answer immediately. There's questions that I have to look up. And there's questions that, while it was good, I can't answer. I still remember my end-of-life Parkinson's patient coming up to me with their walker and her planner in a hand, and I'm like, I'm hoping she doesn't trip and fall, puts the planner before me and asks me to write down the date and time of her death. Can't answer those questions. She wasn't happy with that I wasn't able to answer. As we're going through this in terms of housekeeping again, anything that I say, anything that's in writing, any books that I've written, articles I've written, nothing overrides the policies, rules, and procedures of the Visiting Angels of Richmond, Kentucky. When in doubt, talk to your management. Go through the chain of command. And in terms of this presentation, while I have it meat packed for what you're going to see, I have handouts to go throughout the presentation. If you have questions, and maybe you're like me too, where you have moments that you're so shy that you're just afraid to ask, that's okay. Afterwards, go and talk to your manager. She'll get to me. To the degree that I could freely help, I will do so. So in terms of, and I'm not going to read word for word, but in terms of what we're going to be covering today, we have palliative care and hospice. They're different. We'll go over how they're different and how they're similar. There's going to be a lot of conversation on hospice, eligibility, payment, and so on. We're going to talk about you and your vital nature. I had the privilege when I worked for various hospice agencies in PA to work with the Visiting Angels of York County, and it was always a pleasure. As an organization, your team does well, and I'm so grateful that you're here because you make such a difference in the lives of every patient and every family member that you interact with. We're going to go over some common diseases and disease trajectories and understanding the high-risk areas of what to watch. We're going to go over the dying process. It's 2 parts: the transitioning phase or stage and the active dying phase or stage, and then anticipatory grief and grieving, some of which you might have already encountered in your walk in life. I'm not going to read the learning objectives. We're going to keep things moving. So in terms of palliative care versus hospice, palliative care means comfort care, and hospice is comfort care. It sounds alike, but the difference is that palliative care can happen at any time, any disease process. There's no expectations for how long they're going to live. It could be delivered alongside curative treatments. A cancer patient wanting to go for chemotherapy but struggling with nausea and vomiting, or with pain, or they don't have any treatment that they're receiving. Maybe they have one of those rare diseases for which there are no real treatments, but they're uncomfortable and they need management in order to be comfortable. And I believe, as many doctors and nurses out there believe, that if we have early adoption of palliative care, remember, there's no requirement to be terminally ill. You can get treatment. If there's early adoption, there will be this less push for medical aid in dying. I'm not about taking away somebody's choices and decisions, but I believe that if we address suffering as early as possible, we won't have this pusher saying we treat our dogs and our cats better if we're already managing their symptoms early on. It is often in the hospital or clinic setting, although more and more agencies are trying to deliver this in the home setting, like hospice, a service and not a place. So hospice, terminal prognosis, and I'm going to switch gears to our next slide just to keep things moving. Hospice, the main goal of hospice is a good death. A good death, defined by most people, is removing preventable distress. Hospice eligibility, and I'm going to come back to a good death in a moment. Hospice eligibility, a federal requirement, 6 months or less to live. Now, when we talk about months and we talk about time, we often picture a calendar. When this was scheduled for me to be here today, July 2nd, that was several weeks ago when it was scheduled. And every day was one day closer, and one day closer until we're here. That's your regular calendar. January 1st through December 31st, each day closer. You may have heard of fiscal calendars, June 1st to May 31st. Well, hospice has its own type of calendar, and it's a moving calendar. Well, let's take the case of Jimmy Carter. Former President Jimmy Carter on hospice about 2 years. Well, that's not 6 months. Well, behind the scenes, and we'll get this more in the benefit period when we get to that slide, but behind the scenes, the hospice provider has to prove that Jimmy Carter, every benefit period, still in a terminal state, still has a terminal prognosis of less than 6 months, and here is our documenting evidence to show that we believe what we're saying, signed by a doctor, signed by a nurse under certain circumstances. In terms of the moving calendar, I had a pancreatic cancer patient. I didn't do the admission. I'm going to see the patient for the first time. I'm meeting him and his wife. And I see them, and we're scheduled to come 2 times a week. And we'll get more in the routine, what the level of care in the next slide. I go and see him for the first time, and I tell the wife, this is moving fast. I believe the patient has only 1 month or less to live. The oncologist told the family, and sometimes oncologists will say, I'm just recommending hospice and say nothing. And then we come in and say hospice is for 6 months and less or less. And sometimes the doctors will say, I prefer the nurses. No offense to doctors. I think hospice nurses tend to be more accurate. I am biased. 1 month. And I tell her instead of twice a week, it's going to be 3 times a week. I'm going to be back on Friday. I come back the next time, only a day or two passed. It's really moving fast. And now I'm telling the wife, we're coming daily. He has 2 weeks to live or less. And he did not make 2 weeks. And the wife's head was spinning. We did have to do a lot of emotional support. It was a fast moving cancer. Only God is God. So it's a moving calendar. It's not fixed. It is 6 months or less in order to be eligible. And in order to remain eligible, that proof has to be in place. No curative treatments can be received. So we talk about levels of care. There are 4 levels of care for hospice. The most common is routine care, and that's wherever the patient lives, in a private home, whatever the shape of the home, a personal care home, assisted living, skilled nursing, A hospital or a hospice inpatient facility, and we'll get to those because those have special requirements. But most of the time, it's routine care, which is scheduled visits, and these are not appointments. This isn't blocks of time. I would usually share if it's 2 days a week, I'm coming Mondays and Thursdays or Tuesdays and Fridays. I like to have some spread in between the visits. That allows me to be more accurate for uh, noting decline. Medicare does require a minimum of one skilled nursing visit every 14 days. I think that's too far apart. I like to come, like I even push back if they only want me to come once a week because that's very difficult for me to note how fast somebody is coming to the end. Because if you read any of my articles on compassioncrossing.info, it's about the frequency of changes in condition that's the best indicator for how much longer somebody has to live. The more often I come, the more I see those changes and the more I hear that feedback from the caregivers like yourself. There's also these ad needed visits that hospice is available 24/7, but not there 24/7. So when we get to the second level of care, and that's not in order of the pictures, so routine level of care is the first picture, but I'm going to actually jump down to the continuous care picture on the slide, lower right-hand corner. So with that continuous care, every agency that I've ever worked at, and I've never seen an agency say that they don't offer it. I believe it's a requirement in order to be on Medicare's listing, but very few agencies have the staffing in order to actually execute it. And continuous care, and like inpatient, have very similar requirements. Unmanageable symptoms that can't be managed in the current setting. Now, the difference for continuous care, you're trying to manage it in the current setting, and you're working with a doctor to work to get the pharmacy to get the medications in, and you're there 8 hours. You are doing blocks of time. It's the only time when it is executed that hospice is staffing either home, personal home, or assisted living. Skilled care has nursing staff there, so wouldn't be there under normal circumstances. But inpatient, same deal, but and here's the catch that most people miss in terms of MITs, MYTH, I have trouble pronouncing missing teeth. So you have to have these unmanaged symptoms. So hospice is working with the hospital staff or inpatient, it's their own staff and the doctors to get these symptoms managed and discharged out of the facility back to a lower level of care. They don't go in there with the unmanaged symptoms with the expectation that they're going to die there. They could, but that's not the expectation for Medicare. Medicare is get them in, manage symptoms, get them out. And then respite care, which is the fourth type of care, which is up to 5 days. The family can pay for more if there's availability, but this isn't a Medicare certified skilled nursing facility or a hospice inpatient facility. 5 days every benefit period. Some hospice agencies allow it to happen more often. So when we talk about benefit periods, we're talking 6 months or less. So Medicare breaks that into 3 months, 3 months. So 90 days, 90 days, benefit period one, benefit period two. And because even though Medicare will not physically state there is a God, because Medicare acknowledges that we don't know exactly how long somebody will live, they allow for an unlimited period of unlimited 60-day periods. Now, both the 90 days and all of the 60 days have the fine print, the asterisk, as long as we can prove, as long as the hospice provider can prove on a regular basis that the patient remains in a terminal state. A terminal state is that they could die at any moment. Remember, no one knows exactly when. They could die at any moment, and they have a terminal prognosis of 6 months or less. So as long as we could prove that, they can continue on with services. So when we're talking about this picture, who pays for hospice care? So if the person is on Medicare, it's Medicare Part A. That does not pay for room and board. So if they are at a personal care home, assisted living, skilled care, or hospital, or inpatient, to be honest, on inpatient, I've not worked inpatient, so There may be a fine line as to what is covered from that perspective. I don't want to give information that I would be guessing at for that. So, but Medicare A is what pays for the nurses, the different team members coming in. It's Medicare A is what's paying for the medications that are covered by hospice. So hospice covers all medications directly related to the terminal illness and for comfort as long as they're not experimental. So technically, normally under all circumstances, tongue tied, oh my word, rip out the tongue, put it back in, almost all comfort medications, especially all of the ones we bring in, are going to be covered. Medicaid is a payment source. Sometimes that's where the social worker will come in to get the patient on Medicaid if they're not already on. It could be right now in 2025. This is very controversial for what's happening with our government. We need Medicaid, but there are changes to be made. So we have to be doing a balancing act. But the final word is the patients and family matter. We have to have a heart for them. Private insurance. And when somebody doesn't have any of those, there are hospice agencies that will do this for free. In terms of the hospice team, you have the medical director who does oversight. They have the final say whether somebody gets discharged or not. There are, even though this particular picture does not mention licensed practical nurses, they are nurses too. So some hospice agencies have LPNs and RNs. LPNs are limited for the scope of a practice because they're not able to admit a patient. They're not, even though they may know the prognosis, they should not be writing the prognosis. There are certain things that they're limited for scope of practice. There is the RN case manager, registered nurse case manager. They're the conductor of the orchestra. They're the ones that are doing the most interaction with the patient, the caregivers, and the family members in terms of working with the medical director, the patient's physician. Here are the symptoms, the SBAR situation, background assessment, recommendations, and it's typically the hospice nurses, and if they're properly trained, and I have a lot of books to help with that, by the way. If they're properly trained, we tell the doctor, here's what we need, and the doctor signs off, and we work with the team. We're the ones saying to the aide and the chaplain, the other team members, here's how often they come in, and we're that conductor. Now, as we talked about aides and caregivers like yourself, I cannot speak highly enough of anyone who is a CNA, a home health attendant, a caregiver, because you are grounds on the floor, you are the infantry, you are the first set of eyes, you're spending most of the time compared to anyone else with the patient and the family. And I have had lives made so much different, so much quality improvement because of your communication, your documentation, and from that of my hospice aides. So don't underestimate your value to the team. The chaplain, the most underutilized person on the entire hospice team is the chaplain. They are not there to convert, to proselytize, to steal away and get you to be a part of their, it's not a cult. They are there to support. They are there to encourage. The properly trained registered nurse, the properly trained chaplain and social worker are the best three assets to try to end grief, and the bereavement counsel to try to reduce anxiety of death and dying. No one should fear death, but death, no, who wants to talk about death and dying? It is very common for a patient and the family to go through high levels of anxiety about dying, and your chaplain, your social worker, your nurse, those are valuable resources to the team. Social worker hooks up community resources like the waiver program, where the government, the state will pay for help to come in. uh, VA benefits, other benefits that are out there. Not every hospice provider has a music therapy program. Some do. Pet therapy, massage therapy, aromatherapy. These are different optional items that a hospice provider may have. Uh, every hospice needs to have a volunteer coordinator with one or more volunteers. They are non-medical support professionals. They're like end-of-life dualist, life transition coach. They have a scope of practice for what they're able to do, but they could spend quality time with the patient and the family. They could be writing letters and doing different tasks to help the family. I was a hospice companion volunteer when I was in nursing school, and I would literally be playing video games for a patient with ALS, Lou Gehrig's disease, who couldn't operate the controls. And when I accidentally got their character killed, it was role playing. I would get yelled at for not knowing what I was doing. But it's all well and good. They have grief counselors, and we're going to bring this when we get to the grief slide. But those grief counselors are available to the caregivers, not just the patient. When we talk about the benefit of hospice, it is multifactorial. The patient, the family, the friends, the caregivers, in terms of reaching out for help. Moving on. How can you, as the Visiting Angels of Richmond, Kentucky, how are you helping with this big picture? And the biggest thing is by keeping your eyes and your ears and your senses open to what is going on, proper and timely documentation, and knowing when to call immediately and when to call. And I have here call within 24 hours, but if you're not going to see the patient the next day, you're going to call by the end of your shift. And we talk about calling, we're in a culture for the past couple years, and when I share this, I don't tell anyone what to do. I share best practices and I share my hopes and desires, my wisdom and experience, but you're going to do you at the end of the day, and I'm not going to judge. But my hope is that as a society, we get away from seeing something wrong or bad going on, and we're on our phones and we're calling our friend, or we're videotaping the event and posting it on social media, but we're not interacting and doing the right thing. So my hope is, from the training that you're receiving and what you're hearing today, is that if you see a crisis happening and it's within the policies, procedures, regulations of Visiting Angels of Richmond, Kentucky, your comfort level, your training, you're going to act first. So you're going to act first to go and help. Then you're going to call the hospice provider, unless unless the policy is to call the VA office first. You're going to call the hospice provider. Me personally, not trying to override anybody, I'd call the hospice provider first if it's a crisis, and then I'm going to document. Now, I do want to make note on a couple things. So not everybody on hospice has a DNR, or do not resuscitate, order. It is another falsehood that somebody has to be DNR in order to have hospice. They could be full code. But what is often misunderstood about DNR is DNR only applies when somebody is having a heart attack, respiratory arrest, or they start to actively die. Until those three events, DNR has no meaning, no meaning at that point in time. Now it does. Oh, I wish we lived in a world of no fine print. If you're talking about plans of care, goals of care, and somebody's asking should they go to the hospital, you want to remind them they want comfort, they want to die at home. But really, at what the DNR application is, cardiac arrest, respiratory arrest, they start to actively die. So what that does mean is there's a potential that they could be given antibiotics if they have an infection. When they're choking, if policies, procedures, your comfort level of training, you can do the Heimlich maneuver. You're going to do the Heimlich maneuver. You're not going to say, oh, they're DNR, and let them choke to death. Just being blunt. So you're gonna crisis, call immediately event. You're going to do what you can, and how that might look. They're having a respiratory crisis. It's not respiratory arrest, to be clear. Your training, your policies and procedures allow you to give a nebulizing treatment. You give a nebulizing treatment, and you're being cognizant of the date and time. You give that nebulizing treatment and it doesn't work. They're still having trouble, and you've not received further training, or you have no further direction. You're going to call immediately, because you already acted. You're going to call. Patient was short of breath and proximate time. So to be very, I can't. I like being transparent. I don't know if anybody ever yells at you because you didn't know the exact minute and a second. Reach out to me and I'll help advocate for you. Reach out to your boss. They should advocate for you. They're asking too much. If you can, great. approximate. They started having shortness of breath around this time. I did the nebulizer treatment. It was around 3 to 5 minutes, and they're still short of breath. Could I have a nurse come out? Don't be afraid to ask for a nurse to come out. And part of the handouts that you're receiving, part of it's on the page, but it's also going to be given to you. So that includes space for the hospice number, and just a reminder that when you're in doubt, any doubt whatsoever, call. Any doubt whatsoever, call. Now I like giving real life stories for this. And I do need to go back on one for the main comfort. But for right now, before I go on for this one here, I still remember one of my lady sweet to my heart, a 98-year-old congestive heart failure patient. I did not do the admission, but I was a case manager. I came in and saw her for the first time, and she said, when I told her I'm her nurse, no, 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 you can't be my nurse. Well, why not? Well, you're not a woman and you're not wearing a dress. So I said to her, yeah, I'm a man, and I could wear kilt if you like. And I said it with a more teasing voice. No, 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 you can't be my nurse. You're my bodyguard. And she just like, I'm smiling ear to ear because I'm a geek, I'm a nerd. I don't know if I've ever been in shape in my entire life. And if she wasn't bedbound, she could probably get up and whip me just because I am not that type of person. And so she was dear to my heart. So she came under my care. And so I'm, now seeing her the routine level of care on my schedule basis. And here a different day, I'm with my lung cancer patient in downtown York. And just to talk about some of the other misnomers about hospice and palliative care, this lung cancer patient was taking 20 milligrams of morphine, that's one full syringe, several times a day, and still able to do light housekeeping and function. So I'm in that visit, and I get a call from the office saying that the 98-year-old congestive heart failure patient is completely unresponsive. I have to go there next. We are not EMS, hospice nurses and palliative care. We're not EMS, don't have the siren. I have to complete my visit. Now I'm sharing this to you so that when you do call and say, I need a nurse to come out, it's not like the police stations and the fire stations where they're calling a nurse and we go down the pole and we rush out. This is a nurse who's probably with a patient and family. You still want to call that you're not being a bother. We're going to finish what we're doing. So I had to finish that visit. I had to count meds. I had to call in refills. I had to document the visit. There was no rushing. It's not like, gee, I'm going to cut corners. I finished that visit. I get on a 20-minute drive to get to that congestive heart failure patient. And by the time I got there, I walk in, and this is the day shift. She had 3 shifts, 8 hours, 8 hours, 8 hours. And she had just finished her toast and she's drinking a cup of coffee, chatty Catty. Here's what happened. Third shift, she experienced severe back pain. They gave her a 5 milligram, 0.25 ml. That's 1/4 the syringe of morphine. That's typically a starting dose. And she slept so soundly that the first shift thought that she was starting the dying process. They didn't communicate. So you help hospice by your observations and communication. So one more thing I want to go over, and then I want to go back to the good death part that I missed. And that is in terms of giving you another example for documentation and how this may be a case where maybe a nurse doesn't come out or not. So you're working with Miss Ruth, and Miss Ruth is sitting on the couch, and she asked you to make her a snack. So you go out to the kitchen and you make her a snack, and when you come back in, Miss Ruth is laying on the floor. And you ask her what happened, and Miss Ruth says, I got tired and I just put myself on the floor. So two things. From the nurse perspective, nurses have to treat that as a fall because it's a change of plane. Nurses have to treat it like a fall because it's a change of plane. So that's one where you would check, are you in pain? Are you uncomfortable? And you would go through that. And if she was uncomfortable, you would act. And this is an area where I give a little of caution because I'm going to give you something that technically should be a nurse to assess, and I don't want you to go out of your scope. But if you see, like, if there's blood or her legs don't look like they're what we would say bilaterally equal, which means that they're equal length and they're parallel, or she could straighten out her legs without pain. But if the legs are in any odd, like this looks really painful, you're going to just be with her and not try to get her off the floor. But that's where, again, in doubt, call. Is it safe to get her off the floor? She in pain. If you've not worked through this, if this is somebody that that frequently puts herself on the floor. I had that with a dementia patient at a facility. She'd be walking down the hall. I shouldn't say walking like this because she didn't use a walker, but she'd be like holding the handrail, and she just lay herself down on the floor. Now, if I was there, it's not a fall because I witnessed it. But if it's unwitnessed, change of plane, it's a fall. So that's where you may or may not have to act in terms of getting her off the floor, but that's when you're going to call, and they may say, here's what to do, and then they may not come out. You're just going to document. And again, if it's within 24 hours, but you're not going to be there the next day, you're going to call at the end of your shift. Now, going back to the good death. Sorry, I forgot to share this when we're at that slide. I do want to share in terms of what we add value for. I want to share two quick stories as quick as I can. So the first one, 104-year-old, a 104-year-old who came on the hospice service for a stroke. The doctor, the family, the facility staff, the admitting nurse, and myself, when I first started to see the patient, thought 2 weeks or less. But as I'm coming in as the case manager and I'm seeing things that don't add up, because we use all of our senses, it's not just the vital signs. I'm seeing things that don't act up. I am working with the family. Could I have permission to get her off of all of her blood pressure medication and the anticoagulant commonly known as a blood thinner? Daughter says yes. Then I'm pulling teeth, not literally, with the medical director who is brand new to the agency, and we're all training them as nurses. Please, if everybody's right that it's 2 weeks, she doesn't need this. This is not going to add to her life. And we're slowly. It was like one blood pressure pill at a time. And we got her off of all three, and we got her off the anticoagulant. And within a few days, and we're talking like a day or two of getting her off those medications, she went from being completely bedbound, in and out of consciousness, confused, frequently falling out of bed, to where she's getting herself up, dressing herself except for putting on her bra, getting her walker and using it appropriately to go to the kitchen and dining area to feed herself a regular texture breakfast, to the extent of what a massive improvement. I am going to the entire team. We need to discharge her for failure to decline. She is not in a terminal state. She no longer has a terminal prognosis. She may make it to 105. That's one end of the spectrum. We're not there to kill people. The other end of the spectrum for the good death is that a colon cancer patient who, when I went into their home, to see the patient, get into the living room. I'm doing one of these where the patient's on the couch in such what appeared to be an awkward position. I'm going, are you uncomfortable? And he said, Peter, this is the only position I can get into that I can talk to you and not pass out from the pain. The oncologist said that they can't do anything else for me. What can you do? So I prayed, and I strongly believe God puts us to where we're at. I am the geeky nerd. I know my medications really well. I prayed. I called Dr. Eric Barr. I went with a very aggressive plan for comfort. Dr. Barr, I love you. If you're watching this, gave me the permission to go ahead. We got that on board. And in just days, he's walking around the house functioning. And they were planning for and able to go on their last vacation to Rehoboth Beach. The patient, his wife, and they rescued, foster dogs. They took several greyhounds with them to the beach. That's what hospice is about in terms of a good death. Now, in terms of some common diseases and disease trajectories, what is a trajectory? Well, in hospice, under normal circumstances, it's death. Trajectory, where are you going? What's at the end? It's death. We're all going to die. Now, anybody who comes on the hospice, they have the potential to die at any time. That's that terminal state. So that's the dotted line. Cardiac arrest, respiratory arrest, sudden death. your cancer patients. Our bodies are beautifully and wonderfully made and will compensate as long as possible. So with cancer, what we're looking for, stage 4, it's spread. Metastatic means 2 or more organ involvement. They're not receiving treatment. No one can be receiving treatment for a cure to be on hospice, just to reinforce. So cancer patients usually are coming on board in the middle of this timeline or towards the end. They typically only have a couple weeks left. They don't know it. The oncologist may say, we can't do anything else. They tell them to come on to hospice. They've not declined that much. And I'm dealing with a lot of cases where typically it's the spouse. I think we came on too early. And I'm seeing enough to say, I know this is going to be quick. Please stay. And a week or two passes, and then it's coming down the cliff, so to speak. Your organ failures, that's the wavy line coming down. So that's the in and out of the hospital. Those are your heart failures, your COPD patients. That in and out of the hospital is typically, the medical phrase is exacerbation, if I've not killed the pronunciation. And so with that, uh, the frequent hospitalizations, and each and every one of the valleys, the doctors and the nurses, as good as we can be, really don't know, is this Ethel? Is this going to be the last one? Or is this going to be one where they just have years to go? It is not that much of a science. But for your heart failures, going with this, they're short of breath at rest. The best case to come on to hospice, they're living a bed to chair existence. They're not able to function beyond that. They can't do nothing. Typically, they're on continuous oxygen. We'd call that New York heart failure stage 4. Uh, but they could be a 3, not on oxygen, but they can't do anything. They typically have lower edema, swelling, edema. If they don't, it's highly tightly controlled beds. Your COPD patients, shorter breath, may or may not be on oxygen. They typically will have, in best case, 3 to 5 word dyspnea. So DY, trouble. DY means trouble. NIA, breathing, trouble breathing. So they may get out 3 to 5 words, catch their breath, 3 to 5 words, catch their breath. Frequent infections, upper respiratory, weight loss. If you think about it, breathing takes a lot of energy. And when you're eating, it's very hard to get in good breath. So they're typically losing weight. Your dementia, Alzheimer's. Dementia is an umbrella term. There are 13 known types of dementia, of which Alzheimer's is the most prevalent. What we're looking for hospice eligibility is 6 words a day or less, intelligible, consistent words. Intelligible, consistent words. And they're frequently having trouble swallowing. They may be on a softer diet. Frequent assistant with ADLs, frequent infections. Now, one of the handout areas is a list of the different diagnoses, not just the ones mentioned here. The risks, and I did include a number of diagnoses that won't be primary for hospice, such as diabetes, but they're common. So that's where we can keep things moving along in terms of our presentation. When we talk about the dying process, and while you do have a handout on the dying process as well, let's go over it. So there's two phases or stages. There's the transitioning phase and the active dying phase. Now, my experience and what I've witnessed is a person starts dying 1 to 2 years before actual death. And if we as caregivers can see these declines, and typically it's in bundles, not just one area of focus, we see these going in and out of the hospitals and so on and so forth. We can have these conversations with appropriate parties, palliative care involvement, hospice care involvement. So in the transitioning phase, lethargy. This is extreme exhaustion, heaviness. But the difference between exhaustion and heaviness, where we go to sleep and please don't wake us up, is they're trying to interact with the environment. What that typically looks like, and it may not be the full eyes, and they're, oh, blah, 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 and they're picking at things. They're picking at things not present. They're looking through you. They may have a fixed stare. Their terminal restlessness, and that also known as agitation and delirium. And that needs to be medical managed. One of the areas I try to enforce with every caregiver is in the last year of life. The words discomfort, the words uncomfortable equals pain. The words uncomfortable, discomfort equal pain. The reason I point that out is I had too many families over the years not give pain medication. Oh, they're just uncomfortable. It's synonymous. It needs to be treated, and restlessness is uncomfortable. They're talking to people not present. They're seeing people not present. There is a potential for a rally. So a rally is that burst of energy. We still don't have a good explanation. There's a number of peer-reviewed articles, but I don't know if anybody answers it. This is it. But it's that burst of energy, and it appears differently. Sometimes it's missed because everybody could be sleeping while the patient has it. It could be as simple as the one family that I was seeing, a home pet family where I go there, said, last night was different, Peter. I'm saying, tell me more about it. And they said, Peter, normally the patient's name, they can't stay awake for more than 10 to 15 minutes at a time. But yesterday they were engaged for an hour with us. I knew that was their rally. I knew that was their rally. In other instances, it might be that the patient is barely eating or not eating at all for several days, and they ask for a hamburger, and they were on a pureed diet, but you had grace and mercy, and you had the appropriate safety measures in place. Maybe you cut it into small pieces, and they were able to eat it, all of it. That's a rally. Most of the time, there's one rally, 72 hours, they die. But I've had two separate cases that are rare, and I'm sure you may have encountered or other people. The book has not been complete for certain things. I had a heart failure patient, 92-year-old heart failure patient, who had three rallies over the course of a few weeks, each one less and less intense. And I had another patient, another heart failure patient, who had 4 days in a row of rally, where it was like, wow. Breathing changes are extremely common in the transitioning phase. In and out of consciousness, more time sleeping, leading to the act of dying. We talk about active dying. Most of us tell one another, we tell our friends, I hope when I die, we die in our sleep. That is how it happens the overwhelming majority of the time. We often pass asleep. We're in an unresponsive comatose-like state. Critical, do not under any measures give food or water during anyone unresponsive. Is imagine you're sound asleep and your loved one tries to give you a glass of water. Do not go there. I've had families try to do that. I walk in and they're like, oh, please don't do that. If they were receiving pain medication prior to being unresponsive, they still need it. They still need it. Frequent breathing changes. Cheyenne Stokes, Shane Stoking, different pronunciations for different people, tomato. The possibility of a death rattle. The liquid gets trapped between here, and air going through the liquid makes a gurgling like sound that does not harm them, does not cause them any problems. They're not in distress, but to anyone hearing it, it gets the goosebumps. And oh my word, they must be filling up with fluids. Uh, I'm not saying that somebody never fills up with fluids, but it's not the death rattle. That would have to go beyond 2 weeks. And again, I'm not saying people don't fill up with fluids. I've had one patient come very close. They didn't even have the death rattle. And there are medications, but usually it's position changes that work the best. And one thing to remember is hearing is the last sense to go. So you want to be able to talk to them. Remember, they could still hear you. That does mean that if you're providing care, tell them what you're doing before you do it. That rule does not change just because they're non-responsive. They can hear you. Now, last slide, and I know that this has been jam-packed. I should say last two slides. I'm sorry, just recently cut this into two slides. So anticipatory grief and grieving. Anticipatory grief is you anticipate that the person is going to die. And it is messy. I know a lot of people will describe Elizabeth Kubler-Ross. There's 5 stages of grief. There's anger, there's denial, there's bargaining, there's all these different stages. It is messy. Everyone is different. There's a timeline. And in all transparency, it will never go away. I don't say that to make you feel worse if you're struggling with grief. It gets better, it gets easier to deal with, but it does not go away. And it doesn't go away because you care. Because it exists proves that you care, proves that you love, proves that this person mattered to you. So it can come in waves, unexpectedly. Some days you're wonderful, and other days, wham. And everybody goes through the grief walk differently. You are not alone. You are not alone. Now we're at next to the last slide. The last slide is the questions and answers. So one of the things to remember, and I do want to read this to you. I covered it a couple of days ago. I am not the author. The author is unknown. It's the other serenity prayer. God, grant me the serenity to stop beating myself up for not doing things perfectly. The courage to forgive myself because I'm working to do better, and the wisdom to know that you already love me just as I am. And I don't say that to preach to you in case your belief system is different, but we often put ourselves in a bind that we put ourselves in. So the key here, you're going to validate your feelings. You're going to give yourself mercy and grace and forgiveness. You're going to share your feelings and grief with others. You're going to remember that the hospice grief counselor and the chaplain are resources for you, not just the patient and family. You're going to go on walks, you're going to pray, you're going to get involved with others. You're going to let your manager know if it's too difficult to handle. You are not alone. Now, in terms of supporting families in your own grief, they're grieving too. We have to walk a fine line as caregivers to watch areas that can get us into trouble. We don't want to go and say, we know how you feel. We don't want to use cliches. We don't know how they feel, even if we believe we're feeling the same thing. We want to give them space and honor their space and ask, do you want to talk about their feelings? It might be like, this is hard and very sad. Did you want to talk? And work with and through them. So now we have a time for questions and answers. Now, for those of you from on YouTube that listening to this recording, this is where you can comment in the area below. I'm just I'm looking down. I have been timing myself because this has been constant practice. Part of my OC over compulsive planning is like, is it going to fit the timeline? So I'm so happy that you were able to watch this with me. And as I shared in the introductory session, uh, this is pre-recorded for you, but when I go there, which is you're seeing it while I'm doing it or near close enough, I'm doing everything from memory. As I'm watching my screen, there are not notes. I don't have a teleprompter. I have to do this live in front of them. Just like if I'm walking down the street and somebody asks me, "Hey, Peter, I heard that you're a life transition coach. Can you do me more?" I can't go. Give me a few minutes. Let me go to AI and have AI help me, or let me go to a script. I'm not saying I don't use AI, and I'm not saying I don't ever use a script, but we have to be able to think for ourselves and operate in the real world. And we need to be there for one another. It's my belief. So before I go on too much, I don't want to go down a rabbit trail. I appreciate your time watching this video. If you have any questions, please comment in the comments below. Subscribe, like. As I mentioned, there's not going to be an outro. Thank you and goodbye.